Welcome, and thank you for attending today's HIMSS Learning Center webinar, Using Artificial Intelligence and Predictive Analytics to Reduce Length of Stay, sponsored by Pieces Technology. I'm Bill Sawicki, Managing Editor of Healthcare IT News, and I'll be your moderator today. This presentation will focus on identifying barriers to discharge and how to reduce excess length of stay without having a negative impact on quality. We'll discuss how advanced technologies, such as artificial intelligence, help hospitals better predict real-time capacity and improve patient throughput. Our speakers for today are Nancy Temple, Vice President of Comprehensive Care Management at Baylor Scott White, and Ruben Amarasingham, Founder and CEO of Pieces Technologies. With that, I'll hand it over to Nancy to begin the presentation.
Good afternoon, and thank you for joining us. I'd like to talk to you a little bit about Baylor Scott White. We are the largest not-for-profit healthcare system in Texas and one of the largest in the United States. And we entered into a partnership with Pieces Tech in 2016, working on a readmission risk scoring program. And during that partnership, we found that Pieces Tech also offered a program to help us with our reduction in length of stay efforts. And we have recently installed the RELOS program, which is reduction of length of stay, piloting it at two of our Baylor Scott White hospitals in the North Texas region to help us supplement the operational efforts we are already undergoing. So when you talk about length of stay, let's talk about why it might be a problem. I'm sure most of you on the phone already understand this, but length of stay results in higher costs. It can result in lower reimbursement, decreased patient satisfaction, and as we know, the longer the patient stays in the hospital, the more likely they might have a hospital-acquired condition, and it results in decreased quality of care. So the challenge that we face when we're trying to execute length of stay reduction programs is to determine who is it that can be discharged, and how can we prioritize the limited staff and resources that we have in order to help the staff to prioritize and discharge patients. So currently we have daily huddles or multidisciplinary rounds that are taking place on the floor, and that is a sizable effort. We did a time study at one of our smaller, medium-sized hospitals and found that there were about 900 hours of nursing care and case management put to use when we were trying to huddle and do length of stay efforts. That equates to hours of clinician and administrative time. So what we have found as we have partnered with RELOS at Baylor is that we've had a 3 to 10% decrease in length of stay, and we realize that that is in combination with the operational and clinical efforts that are already ongoing. This is a supplement to those efforts, and it has been the equivalent of 3,500 patient days if you annualized our reduction.
Great. So this is Ruben Amarasingham. Thank you all again. I want to echo Nancy's thoughts about joining us. So a couple of things we've also noticed. One is that Pieces' ability to predict the specific barrier to discharge that patients had was greater than 95%. We had been able to show how we can save 850 hours in nursing review time. That can be a significant amount of time for nurses, case managers, others to determine what are the next steps for patients to be able to get them safely out of the hospital. And specifically, what Pieces does in early identification is it's reading the doctor's notes, reading the social work notes, reading the case management notes in real time, and identifying the top barriers to discharge for each patient, what the operational bottlenecks may be, and how do we continue to find opportunities to navigate the patient through the system. So let me just kind of back up and say, so those are the results. We've been really excited by them at Baylor and other hospitals that are using the RELOS solution. What is Pieces? So Pieces DS, or Decision Sciences, is an artificial intelligence solution that helps optimize clinical and operational decisions in the health system. So how does it do this? What you see on this schematic is just basically the setup of of PIECES. PIECES first takes data from the electronic medical record in real time. Examples of EMRs are Epic, Allscripts, Cerner, McKesson. It takes this data. It can take both data like what we call structured data or laboratory data, vital signs, orders of medications, but it also takes unstructured data like the doctor's notes, nursing notes, case management notes that can be sometimes very difficult to interpret. It takes all that data and organizes it, which is what you see with this arrow. We also have a very specific process that we call clinician in the loop that we'll talk to you about, where our AI system is supervised by physicians on our staff, and that really helps its performance. It takes all this data and then it makes calculations as to what's occurring with the patient, what may impact readmissions, what may impact hospital-associated infections. In this particular presentation, we're talking about reducing excess length of stay, so it would predict where is the patient on their length of stay journey, and we'll show you more of that. Once it identifies all this information in real time, it then sends the insights it's gained back into the electronic medical record where doctors, physicians, nurses, case managers can take action. So this is the loop of how PIECES operates. What does this mean on the ground? How does this work? So we've been working on these kinds of problems for a number of years, and we've identified 5 core steps that we think is really important to improve outcomes and decision making. The first is PIECES will identify what's going on with the patient. What are the characteristics at play? What social factors might be going on with the patient as well as clinical factors. Second, once it's identified that, it's making predictions, predicting adverse events that could occur and notifying the right staff, which is activation. The fourth step is monitoring. Are we doing the right things for this population, for this individual patient? And finally, PIECES learns from every case and continues to improve itself. So using this 5-step process, which we apply to all of the things we work on, including reducing length of stay, we find that you can get really great outcomes. What does this mean for a solution like reducing excess length of stay? So when a patient comes into the hospital, the first thing PIECES does is it's reading the doctor's notes, it's reading the case management social worker notes, it's taking the laboratory data, the medication data, taking all that information and saying, what are the discharge barriers for this patient? What needs to be done today for this patient to be able to go home? And it's looking at a variety of things, including, does this person need a consult? Is there a family discussion? Is there a specific clinical symptom that needs to get resolved? Once it identifies that, it's also then making predictions. Can this patient go home today? What's the likelihood of discharge? Are they, going to meet their expected length of stay, or are they well past it? So those are the predictions it makes. Once it knows that information, you can activate the right personnel a variety of ways. You can see some of the names and categories here for that. And then finally, the PIECES technology team is reviewing to say, hey, are we doing well on length of stay? Are we making progress in reducing length of stay or optimizing it? Are we identifying the right barriers to discharge? Are we doing that and maintaining a good readmission rate? Are we improving our time to discharge? So PIECES is monitoring for all of these things. Certainly the hospital is doing it as well, but we're providing a supplement. And the last step is for in the RELOAD program, using our clinician in the loop artificial intelligence, PIECES continually improves its performances, learning what works, what didn't work, what models are working, and finding areas for workflow improvement. Just to show you, we're going to just, show you a quick demonstration of how PIECES is constantly thinking in the first and second step, identification and prediction. So what you're seeing here is PIECES operating in real time. It's going through and tagging notes, identifying what's important or not important. You can see the various categories that it's assessing. In that particular case, it noted that there's a transesophageal echocardiogram planned for today. That's going to probably affect the patient's length of stay, and that procedure needs to occur. Or, for example, it noted that a patient's refusing a Dobhoff tube, And in the past, at this hospital, when that's occurred, that's affected whether or not the right movement in the treatment plan would occur. This is obviously highly clinical nuance, as you can tell. Down below, you can see that pieces have noted that this person will need an ASP as an outpatient, so it's already kind of thinking ahead about follow-up activities. So the same sorts of things that a doctor or nurse would think about, pieces is assessing in real time to make sure that all the aspects needed for discharge and discharge planning is present. So we're going to demonstrate how administrators use pieces. So what you can see here is a off EMR view of pieces to help administrators with reducing excess length of stay. I want to emphasize that this is one of many views that could be configured inside the EMR and outside the EMR. And what you see here is an administrator level view that hospitals can use to manage its patients. Every dot that you see on the screen represents a patient in the hospital. The higher up they are, the closer they are to discharge, or pieces is saying that the discharge probability is very high. And the farther they are out to the right, is the longer that individual patient is compared to their expected length of stay. So immediately, a health system administrator, a physician, and nurse taking care of the patient or patients can see where the patient is relative to likelihood of discharge today versus their expected length of stay. Very useful information. On the right-hand side, pieces is then assessed each patient and determine what's the next most important discharge barrier that needs to be addressed. You see a variety of different categories that pieces is assessed. For example, consultation feedback, diagnostic test needed, a family discussion. For example, it might be a patient that is related to end-of-life care decision-making, and the palliative care service needs to come and speak with the patient. Follow-up arrangements that might need to occur as an outpatient. Health-related social needs, like social determinants of health. In this example, transportation has been cited. Medical supplies, medication issue. You can even see that pieces determined for this hospital that state agency-related delays was an area that frequently came up and pieces characterized. So pieces read all the doctor's notes, nurse's notes, case management notes, and then determined that this is the most important barrier that the patient faces. And you can see for each of the dots that are represented, it is labeled with the color that represents the discharge barrier. So let's look at one particular intervention category to start off with, consultation feedback. And we can see that pieces is now filtering based on the individual's needs. You can see these are all the patients in the hospital right now whose discharge is pending feedback from a consultation service. So pieces was able to read the notes, as I mentioned, and determine that. So let's look at one of these patients down below. The person's name is Aisa Leon, and she came in with pneumonia. It was unspecified. And pieces said consultation feedback is needed, and specifically, it was even able to cite the notes from the physicians where they said transition to PO backroom for home is needed, and still awaiting infectious disease recommendations. So very clear that the ID service needs to come by. It was able to prioritize and isolate that information. And if you keep going on this chart, you can see that the probability of the patient's discharge is 90%. Their normal expected length of stay is 9 days, and currently they're at 6 days. The piece is making an assessment at day 6. So you would, if the patient was successfully discharged, if you had the infectious disease service come by, you would be saving 3 days on the length of stay, which is very significant for the hospital. Another example is Elder Purity. She's coming in with a rectal abscess, and pieces specifically noted that what we're waiting on for this patient is emergency general surgery recommendations. And you can see the impact on the discharge if that were to occur. So again, pieces is able to stay very nuanced. Let's move to a different area. Imagine all the patients who need symptoms resolved before they can proceed. And so you see a different set of patients here. And let's look at this patient, Concepcion Anvika. So here she's coming in with malignant neoplasm of the anus, so likely a surgery patient. And pieces said, symptom needs to be resolved. And specifically, it noted that the surgeon had said discharges pending return of bowel function. So very clinically nuanced. It was able to identify that information from other information in the chart and said this is the important information, very useful, for example, to nursing and other groups that are taking care of the patients. The patient's probability of discharge is 77%, and if you were able to discharge this patient, you would be able to at least prevent an excess length of stay of additional 2 days. So very important to get this patient and follow through with their symptom resolution. So what I wanted to do here was just kind of also talk about different ways we can present the data in terms of bar charts and information. So just other really exciting ways that pieces can be used that our health systems have found very helpful. You can see, for example, you can characterize each of the patients in the hospital that need post-discharge placement. You can see at this particular hospital, there's 37 patients awaiting post-discharge placement. What's meant by intervention category 1 is that this is the #1 issue. And then you can also see down at the bottom, you can classify all of this by different service lines, internal medicine, surgery, observation patients, burn patients. So again, allows for individuals to get really focused, and you can hit those bars, charts, or this information go directly to the patient list that they represent. So been very useful. A variety of ways that this information can be presented. And finally here, we're just returning to our normal home screen. Again, this is one view that can be used, and we can also, as we'll show in the next slide, use it in other views. One of the ways that pieces can be configured is that we can send the alerts directly within the electronic medical record. That can occur directly through the paging systems or smartphone applications. It can send it in a system list within the electronic medical record. So what you're seeing on that big monitor is a list of patients, and pieces is populated with the correct information. We can send best practice advisory information, or we can send information in different views, which you're seeing in the Mac display. So pieces is fully integrated in the electronic medical record. Here's another example that really shows a lot of information around that pieces is preventing. So here's a patient list, and you can see that for each patient it says kind of, is this patient ready for discharge? Where are they? And this is not based on any checklist. This is based on pieces reading and interpreting the notes and the documentation the way a physician would, and assessing all that information, saying this person's 60% ready for discharge compared to another person, and in fact can balance it against, hey, what's the risk of readmission? So that patient below, Deborah James, is 80% readiness for discharge, but there's a pretty high risk for readmission, so you need to consider it. And pieces in providing an insight, it said this person's homeless and non-compliant with medications, and that's what's driving the readmission risk. One of the things that pieces is able to do very successfully is address and review for social determinants of health as much as clinical factors. And then on the third side, you can see pieces has identified these are the barriers, the discharge steps that need to occur. And for example, GI needs to see this patient in the morning. We're still waiting a fetal occult blood test pending. There's an obtaining and stool cultures. And it's crossing out things that have already occurred. So nutrition consult placed for tube feed evaluation, that's occurred. So you can see in one view, pieces is giving quite a bit of information on important insights as well as barriers that have been crossed that would impact the length of stay. One of the things that is pretty significant about this application is that you can see that the pieces AI system is reading the notes and interpreting the clinical and other structured documentation the way a physician would. And it does that. We know that in the electronic medical records and in the data, there's a lot of ambiguity. Data information may be missing, a progress note may be missing, there might be laboratory data that's delayed. And in all of those circumstances, there's levels of ambiguity. There may be physicians that disagree or consultants that disagree. And so one of the elements that pieces does is that where as it learns in a new hospital system, it relies on clinicians on the piece of technologies team to continue to improve it. And so this is called clinician in the loop, and this process is used to really configure pieces to be very accurate. So what you're seeing on the screen is live shots of pieces interacting with clinicians. Each of those views are different patients, where it's interacting with clinicians, and it learns very rapidly your local environment, so that a hospital in Iowa will have different documentation practices than a hospital, let's say, in Atlanta. And all of that is captured and learned by pieces through this clinician-in-the-loop AI system. One of the things that is important is, obviously reducing length of stay is a multifactorial problem. You have clinical leadership involved. They want to know, how are my physicians doing? How are my nurses doing? And so pieces provides a holistic sort of retrospective view, as well as a prospective view of what's occurring. So you can see how are we doing on things like consultation. When we make a consultation, how quickly does it occur? So that's very important. Obviously, the clinical care team, they want to know right now what are the things that I need to be doing that I need to be prioritizing, not only for a given patient, but across my patients. So that's important. On the operations side, the hospital and the health system wants to determine, hey, how can I find the bottlenecks, and what are the discharge protocols that I need to be improving on? So pieces provides information and insights from that. And finally, the biggest, obviously a huge driver is finance. You want to improve cost avoidance by identifying and removing process inefficiencies. So these are the stakeholders that we've found has been really important for this kind of work. And I want to just offer Nancy if she wants to comment from her Baylor experience.
Yes, what I would say, one of the biggest learning curves that we've had at Baylor as we've been using the RELOS program is that there has been an opportunity for improvement in physician and care management documentation, because as PCES is reading the notes and creating the barriers or listing the barriers to discharge, if the notes aren't reflective of that, then it's not reading anything that would give you good information. So we have really learned to hone in on our documentation and provide cues for our hospitalist team and for our care management team in order for PCES to really get the kind of information that we need in order to make the report one that we can act upon. I think that's been our greatest learning curve.
And thank you for that, Nancy. So I think there's one of the secondary benefits also of PCES being in there is that we think that you're going to get constant improvements in a variety of areas because PCES is reviewing all this data, in addition to the main area, which would be something like reducing length of stay. PCES is, we have a number of different modules that we offer. So I think we've spoken about reducing length of stay. We also have done significant amount of work in readmissions, reducing readmissions and avoidable hospitalization. We would say that length of stay is very related to the problem of readmissions, and so many of the health systems that are using PCES are using both modules. Hospital-associated infections, obviously a critical problem, so the same type of artificial intelligence approach is used for understanding how we reduce healthcare-associated infections. PCES has been used for things like inpatient deterioration, so identifying individuals who are rapidly deteriorating in the inpatient setting and need to be flagged for potentially moving to the intensive care unit or greater intensive care. That's very related to the problem of sepsis, where you're trying to reduce mortality and complications from sepsis. So a lot of work there. PCES providing real-time support for that. And then one of the really exciting things about PCES is that we're able to build custom decision support or AI work for health systems. We have more than 20 different additional modules in areas specifically to reduce complications of care in the inpatient and outpatient setting, improving value-based care, and maximizing patient outcomes. One of the things I just kind of wanted to summarize was that, kind of how do we see PCES as different? PCES employs a proprietary clinical natural language processing solution, so we're able to read interpret the unstructured text notes in real time. One of the things I dwell on here is that Pieces is able to come up with clinical understanding. So rather than just tagging notes, it's understanding, hey, this person refused a Dopphoff tube, and this results in secondary problems for the patient. So it comes up with meta-level understanding the way a clinician might think. Pieces is very precise, so we're very focused on high performance and making sure we activate and focus the care team only when necessary. One example as an example is in our sepsis work, Pieces will look at not only this person is at risk for sepsis, but is the doctor aware? It's reading the notes, looking at the doctor's activity. If the doctor is aware, it's not going to be communicating with the doctor. So it's trying to think the way that I, as a physician, would think about communicating with another physician. Our clinician in the loop, obviously, that's our way that the AI systems can be maximized. So we think that human supervision of AI systems are needed in medicine right now. And so the machine learning can continually improve that way. All of our algorithms are evidence-based, which allows for which is very clinically focused and then allows for ongoing tuning. As I mentioned already, the models are really focused on working in clinical practice. We have our own performance thresholds of achieving positive predictive values of 90 to 95% and a sensitivity of 80 to 95%. Again, as I mentioned, we use structured and unstructured free text, and we work on a really strong cloud environment that's very fast and very secure. And I think with that, we're going to open it up to questions.
Okay, great. Thank you both for that very informative presentation. I want to first remind everyone that you can continue to submit questions using the Ask a Question panel on your screen. So, for our first question, how long did the program, i.e. Pieces LOS, take to create? How long was validation, and how long did it take to implement link to live data streams?
Great question. I think what you mean is when Pieces comes into a new hospital using the clinician in the loop approach, how fast does it get validated? So Pieces learns very quickly when it goes in a new hospital environment. So depending on the problem that it's solving, it can be from days to weeks. And it's essentially using the clinician in the loop process, it configures and learns within that system very rapidly. We want to see in our validation that it's achieving 95% performance in positive predictive value and other components, and then it's deployed. And then it's constantly being monitored after that. So it's relatively rapid validation process at the hospital.
Excellent. Our next question from the audience, this one is for Baylor. Does this DS tool utilize data from your HIE?
So it's pulling data out of our electronic health records and then building lists for us for our length of stay patients, giving us the barriers to discharge and the estimated length of stay. And one of the great things about working with the Pieces team is that as we found that there was additional information that would benefit the clinicians, we would work with our project managers and ask if that could be added to the report, and they have always been able to help build, like Ruben said, it's constantly learning and updating, and they will help us with getting the additional information into the report so that it would benefit all of the clinicians using the report.
Very good. Our next question. Can you elaborate on the role of the Pieces clinician that monitors the algorithm? Can you provide an example of how a Pieces clinician might alter or enhance the results of the algorithm?
Absolutely. So I want to first state that the Pieces clinician is involved before go live, and so it's during the process of the algorithm's performance improving. And so an example might be, I'll just give an example that, Pieces was learning in a new hospital, and in one hospital, 7SS was a floor of the hospital, and in another hospital, 7SS was a diabetes protocol, and it had learned in one hospital what a certain component understanding was, and it was appropriately re-educated by the clinician at Pieces Technologies that in fact, in the context in which 7SS was located, is actually represents a floor. So that's an example of how the algorithm can get more and more complicated and complex and reflect the local practices and language based on the clinician. So it does that. And then again, remember that the algorithm is constantly getting tuned on these validation sets to get a high level of accuracy and performance that's independently validated to 95%. Great question. Thank you.
Very good. Our next question from the audience. Do case managers, care coordinators, and transition of care managers all have access to this tool, or only case management?
So we at Baylor have chosen to give anybody that wants access to the tool. So our hospitalists have access, our care managers have access, a couple of the administrators have access, and what they practice has been, the care managers, social workers will take the report with them to their multidisciplinary rounds and share it with the teams. So therefore the physical therapists are having access, and the pharmacy team, whoever is attending those multidisciplinary huddles.
And I'll add, and that's been great, and it's worked really well at Baylor. Pieces is such that depending on what the health system's preference or choices are, it can be configured to whichever users are relevant. And the reason, just as a clinical example, hospitals are structured differently. In fact, this is why the models need to be configured locally. For example, in our readmission program, you can have health systems who choose to attack the problem of readmissions by having a centralized case management department that is handling high-risk readmissions, right? So 6 case managers just focused on the high-risk readmissions. So they would be the ones interacting with Pieces. There's other health systems where every case manager is responsible for the high-risk readmissions patients on their patient list, and Pieces will then notify all the case managers. So one of the things that we think is valuable about Pieces is it can be architected quickly to determining how the hospital structure is set up, and the models behind it will also be set up the way the hospital is set up.
Okay, our next question. Can you talk more about how you use social determinants of health in your models?
Fantastic. I love that question. We've focused on that problem for more than 10 years now in terms of our full research experience. First of all, totally agree. Social determinants is critical, particularly for things like readmissions and even length of stay when you're optimizing, because you want to make sure you have a safe discharge plan. So the way Pieces works to do that is it's reading the doctor's notes, the nursing notes, social worker notes. We find that those notes, those narrative notes and even structured notes, are replete with information on social determinants. Without ever asking, oftentimes doctors are writing about there's a consideration around the person's housing status, or clearly case managers, social workers. So Pieces is scouring the notes in real time for that, reading those notes, identifying what the health-related social needs are. There's multiple categories of health-related social needs. It identifies that, and then it's making sure that the appropriate personnel would be aware of the social determinants of health so that can be incorporated in the discharge planning. So, and then health systems obviously have different responses to that. And when we work with health systems, we'd want to marry up their responses to any given problem as part of their workflow, and it's an important part of the implementation. So Hospital A will have a program to deal with homeless patients that might be different than Hospital B, and Pieces can activate the right people and workflows based on what that approach is. So have a huge belief in social determinants of health. Pieces specifically looking for that and making sure that the discharge planning and other things, that's an awareness by the health system. One of the other things I would mention with that is that we hope that we think there's a lot of information in the chart about social determinants, And one of our goals is that without having to create a lot more structured documentation, we can elicit a lot of that information so health systems can use it.
Excellent. The next question. What were the challenges regarding organizational change management, and how did you overcome them?
Well, I think that it was one of the greatest challenges was just to get everyone kind of on board, moving towards the same goal. So getting everyone in the room to discuss the importance of length of stay reduction, because each team member carries a different perspective, shall we speak, on length of stay. So getting the hospitalists in the room with the care managers, and then also the nursing staff, because what we found with nursing, and I'm a nurse myself, is that sometimes their care is very episodic, so they're not with the patient the entire stay. So they're taking care of that 12 hours or maybe those 2 days of 12-hour shifts. So getting everybody to see the importance, and pieces helped us to prioritize, like Ruben had said, so that a hospitalist, one of the big learning things that we have is when the hospitalists are changing staff, rotating on, rotating off, that list is available for them to look at, and it kind of gives them at a glance where their patients are. They certainly check out with their partners, but this is just a real-time documentation of those kind of priorities. So change management was accepting the tool, was accepting the validity of the tool, and then how are we going to action the information? And it's a team sport. It's really taken a lot of participation in all of the different disciplines in order to make it an effective tool.
Awesome. And I might add to Nancy, I think one of the things is, obviously, when you have physicians involved and nurses involved, the output of the information needs to be really clinically credible. So I think that's one of the things that in the current world of kind of decision support, you have just these crude alerts. But if you can start, providing information that's very nuanced and granular clinically, I think the receipt of that is a lot more. So.
Very good. Our next question. To eliminate bottlenecks with AI interpreting free text or provider's notes, have you considered using templates or standard forms so that keywords are used in documentation and can act as a reminder to the provider so this can effectively analyze it?
So I speak to Baylor's use, and we have found that would be beneficial, and particularly where we are further along in the use and have been using the readmission risk scoring system a little bit longer. And as we have gotten into our third phase of implementation of that, we're looking for what interventions are working to reduce readmissions. And in order for now we want to go back and validate if this patient had all of these interventions, did they readmit or not. And in order for pieces to pull that out, we have worked on creating templates and slick text in our medical records for our physicians or for our providers so that the information is easily pulled out of the medical record. So in answer to your question, yes, I think that would be beneficial to build some templates or some slick text dependent upon your medical record. We use all scripts at Baylor right now in North Texas.
Very good.
This is Ruben. I would concur with that. I think there's, depending on how health systems are set up, there's a variety of ways to try to make sure that this information can get in, and then pieces can pull it either out of unstructured or structured data. And even in the templates, you sometimes have unstructured. Mm-hmm. So there'd be a box and say type in whatever, they could type in free text whatever they want, but it's a little bit more of a prompt. So I think in certain cases that can be very useful.
Very good. Our next question. How is the discharge probability defined? How do you evaluate what factors are attributed to such probability for patient A versus patient B?
So the discharge probability is defined as the likelihood that this patient will be discharged in the next 24-hour period. So that's the definition of the discharge probability. And that's essentially the goal of the mathematical modeling, is to using all the prior data and its learning at that hospital to accurately forecast, given all the clinical activity around the patient, given the non-clinical activity, where this patient might be, what kinds of discharge, what are the specific discharge barriers that we're waiting for. For example, a CT scan for a given patient with this condition may be longer than, let's say, another radiologic test, for example. So all those factors factor in, as well as like what are the issues to give the probability of discharge. And PIECES operates at a high predictive level on that front. So that's the definition of the discharge within 24 hours. And of course, it can be validated because we can see what's actually happening with those patients afterwards.
Very good. How accurate is your model software regarding the problem with sepsis, which was mentioned during the webinar?
Yeah, absolutely. So right now, all of our models perform at a positive predictive value of 90 to 95% and a sensitivity of 80 to 95%. So that's the same level of performance for sepsis. One thing I would like to say is that, similar to reducing length of stay, we don't think it's just one decision point in time or one model. For sepsis, we're identifying is a patient at risk for sepsis. There's multiple models going on for that because there's present on admission sepsis, there's non-present on admission sepsis, very different clinical problems. Are the clinical teams aware and taking the right steps? So are we following the clinical or therapeutic protocol around bundles and other critical information? Are we following the time frames? And then is the patient deteriorating? Do they need to potentially go to the intensive care unit or other place? So I just listed about 20 models right there. And our goal is for all of those models to be performing at a very high performance. So it's not just is the person at risk for sepsis. It's throughout the sepsis continuum, are the right things occurring in identifying those right things.
Very good. Next question. So our next question, what patient's data do you request from the EHR? All the activities, notes, lab results, CPOE, nurse plan?
Yeah, that's a great question, and it all depends on the hospital. So, definitely contact us, and we can provide that information. We obviously traffic in notes data as well as laboratory and other structured data. It's quite an important set that we select for that.
Okay.
So
how much data is?
We could definitely give more specifics. Just call us, and we'll configure it for you.
Okay. How much data is needed to construct meaningful results?
Well, I mean, how much data, I think is a term, it can be interpreted a lot of different ways. We're able to basically, we'll take the data that we're available to take and be able to configure, and then pieces we continually learn. Typically, we have specific requirements around a small set of prior data, and then there will be ongoing learning as pieces go through its validation process.
Very good. Our next question. So each instance at a facility is using 1.0 and learning from there. Would there be value to using an algorithm from, say, Baylor and then tweaking from there for my facility?
Yeah, great question. That's how pieces operates. We never mix. Obviously, data is never mixed, but pieces learns from every hospital it's deployed in, and then when it goes in the new facility, it will reconfigure to that new facility. But its learning time is significantly shortened because it continues to see more and more from different hospitals. And obviously the clinician in the loop process allows us to get highly configured, but it's learning simultaneously from all the hospitals it's deployed in, and that knowledge base is contributing to the next hospital.
Okay. Next up, is there a list of EHRs and other hospital software and hardware that are compatible with this software?
Yeah, so I think we mentioned before Epic, McKesson, Cerner, and Allscripts.
Very good. What is your accuracy test values for LOS prediction in your validation?
What is the accuracy of the validation? Can you repeat that question again? Sorry.
What is your accuracy test values for LOS prediction in your validation?
95%.
Okay. How is PIECES reducing issues regarding selection bias in large health data sets?
So that's a great question, an important technical question that we have, I think, got very elegant approaches to. Probably can't be answered in just a small response, but happy to talk to the questioner on that. Please, provide your information afterwards. We have worked. We have a particular approach to handling the problem of selection bias, and one great aspect is because we have this clinician-in-the-loop process. That clinician-in-the-loop process is part of our validation approach to deal with selection bias.
Very good. At this time, we have to wrap up. Thanks again to Nancy and Ruben for that terrific presentation. Please be sure to complete the evaluation at the conclusion of today's event and share your thoughts with us. As a reminder, today's session will be available on demand until October 23rd, 2018 through the HIMSS Learning Center. Have a great day.